First, if somebody has the medial and lateral epicondylitis, you don't need to treat the shoulder. Is that true?
No.
You need to treat like a whole shoulder from the posterior part, and then the maybe opening of the chest is important. So I've done everything already. Okay, and then I'm gonna move on to the elbow area now. So you're gonna loosen up upper part of the arm too, right? Like the triceps and then the biceps and brachialis, everything you've done, and then you can warm up the tissues here too. The one thing that you may need to be careful, I need the one for it later. So then, this condition, your patient are using the muscle, like contracting a lot, right? Which means it's kind of pulled a lot like that way. So your patient has a tear here, right? So then, are you gonna drag the tissue away a lot, like this way stripping? No. It's not a very good idea, right? So same thing for the extensors too. The direction of the stripping would be going toward would be better than like this tall way, right? So gotta be careful with that one. And then like there is we talked about it, is it Tuesday, right? So then there are like different layer of the compartment on the forearm and then the anterior and posterior side, right? So you can target all the compartment side to actually loosen up the fascia structure there. So can you slide a little bit further there? So there's a bit of better space. Yeah. And what I usually see from the OP exams, like sometimes you guys try to pillow your patients to put the pillow under their elbow like that way. So then is it like a resting position? No. Not really, right? So you need to have the pillow in a right place so your patient can rest their hand and then the wrist area like a relaxed position, right? And sometimes because of the table wise it's not really space enough, then you can ask your patient to move a little bit toward the other side so you have the better space here, right? And then you can kind of try to have the covering of the compartment structure and then move along to release it. And with their motion too, you can ask your patient to actively do the motion, or you can do the motion for them too, right? So you can release those ones for the medial side, and then the lateral side too. Same thing, like those things. And then where they attach onto the elbow is the medial and lateral epicondyle, right? And do you remember there is a septum structure, right? So have you guys seen the septum release for those spots? So for the lateral part, you're gonna go to the lateral epicondyle, and then one finger is stabilizing here, and then the other one you can use the thumb or the index finger depending on what is more comfortable for you. Stabilize here, and then you're gonna try to go along the septum to give a little bit of the release there. So there is an anterior compartment for the upper arm, and then the posterior compartment for the upper arm too here, right? So between the biceps and brachialis and triceps, there is a septum. There's always covering the fascia structure, and then it kind of thickened in between here, especially from the lateral epicondyle along up. You don't need to go all the way up, because when you kind of go like a 1/3 of their length of the humerus, then the septum is disappear because the muscle is kind of get bigger too. So you don't need to go all the way up, just the close to the lateral epicondyle, and you can try to perform to separate the septum. And same thing for the medial side too. So you're gonna have your patient arm relaxed, and then find their medial epicondyle, and then the release, like separating. Same thing too. Just you need to be careful more on the medial side, just because of the neurovascular bundle that containing the median ulnar nerves and then the brachial artery coming along down here, and it kind of punctured through, especially the ulnar nerve in the medial side of the septum, and it goes to the posterior side of it. So when you are going too far up, so then you may compress the ulnar nerve where it punctured through, so then your patient may feel the numbness tingling here. So gotta be careful. You don't need to go all the way up, just a little bit, like 1/3 of the length of the humerus, and that's usually enough. And the septum structure feels different than the muscle belly. So when you try this separation, you can feel that it's more like kind of firm, more like leathery types of the structure. And when you are on the muscle belly, you can feel it kind of softening because it's the muscle belly. You can kind of feel the difference too. So you don't need to reach too all the way up there, right? And then, so like for the medial epicondylitis, there is two muscles that involved most. It's gonna be the pronator teres, there you go, and then the flexor carpi radialis, right? So then you can kind of have the pronator teres itself has the own sleeve wrapping around the muscle itself. So you can kind of try to loosen up that portion by holding the structure. And then with the motion, it can be active too. You can ask your patient to do that motion while you are doing so. So you need to find the where pronator teres is attached onto. There is an anatomical variation that sometimes their attachment point is a bit higher up or lower. So you can actually feel the muscle if you cannot really feel where is the muscle. But like along the radius, there is a tuberous, the tubercle for the pronator teres. And then you can kind of go from there to loosen up those structures. So that's the more the superficial techniques that you can do for this one. And then obviously like a lot of muscle work on the flexors or the extensor depending on which condition you are targeting to. It's important to warm it up first, right? And then maybe you can perform some trigger point release too. It is very common that your patient have some trigger point, especially for the extensor one. And when you are compressing those areas, so then you can easily provoke the thing. She has a little bit of the action too when I compressing the extensor carpi radialis brevis. So then you will see that usually with a little bit of the extension motion, when you are on the extensor carpi radialis longus, so then you may see that your patient has a radial deviation, kind of the twitches. That's gonna be the trigger point reaction. And for the brevis, it's more of like extension motion. And when you are on the extensor digitorum and you find the issue, usually you will see that their hand finger is kind of opening up. So there's extension, especially the middle finger. And then for the ulnaris, if you are pressing down the muscle belly of the extensor carpi ulnaris, then your patient have a little bit of the ulnar deviation, kind of the twitches. So depending on that, you can loosen up the trigger point on the extensors. And then what else? So like I warmed up all the tissue and then get rid of all the trigger point, and then now I feel like I'm ready for the friction on the specific spot. So for the medial epicondylitis, so you're gonna go to the which junction now? There is a tenoperineal junction, right? So where the tendon attaches onto the bone. So you're gonna go very close to the medial epicondyle itself, and then find the junction where it attaches onto, where your patient feel the exquisite tenderness. That's the spot usually, and then you can perform the friction now, right? So then friction, usually it's crossfire friction. So then your direction of the crossfire friction is gonna be like this way, right? So you're not doing like that direction, right? It's more like this direction. And how about the lateral epicondylitis now? What is the target muscle usually? Extensor carpi radialis brevis, right? So when it crosses over the radial head, that's the most muscular tendinous junction for the extensor carpi radialis brevis. So then you're gonna find the lateral epicondyle and then feel the head, and that's the junction, right? So then the muscle runs like this way. So then your direction of the friction is gonna be across like that way, right? Not like this way, right? So you need to find first where is the radial head and your ligament, and then you're gonna go from there, right? Usually that's the spot your patient develops the adhesions. Right? So after the friction, you're gonna do a little bit of stretch, and then the eyes, like that's the procedure, and then you can keep going, right? So those are the techniques that you can do.
Supinator. Supinator.
Supinator what?
How to treat the supinator?
So you can go directly go to the muscle. Usually that's what you usually do because it's the deeper structure. It's gonna be hard to do any fascial release. It's like you can try it, but spinator kind of wrapping around the radius, and then it's kind of deep to all these extensors. So the kind of loosening of the fascia structure on the top, it's not gonna be easy. You can working on the muscle belly more in the spinator, but not really like the pronator kind of the way, because it's most superficial one here.
Is there any indirect technique for the supinator? Because I know some patients, they just can do this and feel soreness on their
When your patients cannot do any motion, limited range of motion, then you need to figure out what causing it. It can be from the muscle, usually like not the muscle that is putting into the motion. Maybe the other opposite muscle doesn't let go, so they may feel hard to do that motion, or they may have the hypermobility at the joint. That's why they cannot achieve the full range of motion. So you need to decide first what causing the restriction, and then your treatment follows.
But my patient just needed to do this during her work. So now she has some pain on the lateral side of the elbow, epicondyle. So I think maybe the supinator one.
So you can treat the where the spinator is attached onto too, right? That's the annular ligament. Yeah. So your patient may have the adhesion developed there from the old like repetitive movement. So then you need to check that area and then maybe perform some friction on there. That usually works better with the patient.
Annular ligament.
Yeah. Okay.
Thank you.
Any other questions? Okay. Are you guys ready to treat? So this